Thank you very much, organizers, for giving me this opportunity to present this novel technique of myocardial blood flow and myocardial blood flow reserve through CZT-based dynamic gated SPECT myocardial perfusion imaging. I don't have any disclosures. SPECT myocardial perfusion imaging is a time-tested diagnostic and prognostic modality which is supported by a wealth of huge observational and clinical trial data collected during the past 5 decades. However, its performance is limited by a fundamental drawback, and that it assesses the relative perfusion of regional myocardium in relation to the area with highest myocardial perfusion or tracer uptake. So there is a fundamental drawback that in cases with global reduction in the myocardial perfusion, the assessment is underdetected and it remains underestimated. Previously, we used to address this challenge and try to tackle this issue with the qualitative assessment of the tracer uptake and by evaluation of transient ischemic dilatation and lung uptake. But recently, this limitation has been addressed amicably by the most exciting and useful advances in the nuclear cardiology by measuring the myocardial blood flow and blood flow reserve. There are no absolute clinical indications or clinical applications. However, clinical data shows that incorporating this dynamic imaging into the traditional myocardial perfusion imaging improves diagnosis of epicardial disease and improves the sensitivity up to 95% from typical 80 to 85%. It improves the assessment of extent and severity of epicardial disease, and it improves risk stratification due to its high negative predictive value of up to 97%. There was an interesting study by Murree et al., and that group studied up to 200 patients with PET myocardial perfusion imaging, and the interpreting physicians were given the data of the perfusion images, and they were asked to classify the cases. And again, they were given the flow data, and it was amazing that up to 50% of the cases were reclassified on the basis of dynamic imaging and on the basis of myocardial blood flow and MFR. So this shows the strength of this new novel technique. Further, it improves the patient selection for coronary intervention and medical therapy. It also diagnoses coronary microvascular disease, and it confirms the effectiveness of pharmacological stress and identifies non-responders. Incorporating this dynamic imaging into the conventional gated SPECT myocardial perfusion imaging, it measures the blood flow after the injection in real time and during the stress and rest phases, and quantifies the relative perfusion as well as quantification of myocardial blood flow in ml per gram per minute. We take the values of myocardial blood flow during stress and rest phase, take the ratio, and that is called myocardial flow reserve. It does not involve any additional time or radiation dose, and it assesses the entirety of coronary delivery system, including the epicardial coronaries and the microvasculature. So I'll briefly present the protocol. We use this technique with technetium-99m MeB with adenosine-induced stress, and we acquire the images on our recent and latest machine CZT-based gated SPECT cardiac dedicated gamma camera. And other radio tracers are available for the PET imaging like rubidium, N13, O15, and recently introduced fluoperitons. We acquire the dynamic images during rest and stress phase images, and followed by the static images in the supine position and the patient-friendly upright position. We quantify the data acquired through different softwares like QPS, QGS, and INVIA, and we evaluate that gives us the estimation of myocardial blood flow and MFR, alongside the traditionally acquired different functional parameters like LV volume, ejection fraction, total perfusion deficit, transient ischemic dilatation, and ischemic burden. So this is the general interpretation of and relative risk in relation to the global MBFR. Typically, a value greater than 2 is associated with the low risk and is interpreted as a normal scan. Studies show that MFR value less than 1.6 is associated with 6-fold increased risk of MACE. So coming over to a few clinical cases. 58 years of age, hypertensive gentleman presented with chest discomfort. 2T echo was normal, and we did traditional SPECT MPI with MBF and MFR protocol. There was no significant adenosine-induced ischemia, and the global MBF and MFR values were normal. Here we see homogeneous tracer uptake in the stress as well as in the rest studies, and the functional images are good, and there is adequate rise in the flow images during the stress phase. There is homogeneous uptake in all 3 planes, and we acquired this data of the MBF where we saw that there was normal stress MBF and MFR values. So this normal MBF confirms the normalcy of the study, and it confirms and indicates low risk of CAD and further confirms low risk for major coronary related events. Another interesting case, we did it just 3 days back, and this was 35 years of age diabetic gentleman, Naswar user, known patient of diabetic nephropathy, taking antipsychotics and antidepressants, presented with exertional dyspnea. Echo showed global hypokinesia with severe LV dysfunction and EF of 26%. And gated images showed mild ischemia involving parts of inferior, posterolateral, and apical region. Coronary angiography showed severe triple vessel disease involving the LMS. We did the MFR and MBF study as well that showed severe reduction in the stress myocardial blood flow and severe reduction in the MFR. So we classified this patient as high risk. So I'll quickly go through another case. This was a patient with recent history of anterior wall MI and with the primary PCI. Perfusion images showed mild reduction in the apical and adjoining part of anteroseptal region, whereas we acquired the MBF and MFR studies, which showed moderate reduction in the regional as well as the global MBF and MFR values. And another case, this was a normal case, but here we did not see any rise in the stress myocardial blood flow. So this was an inadequate response to the vasodilator. These are few of the factors affecting the MBF. So lastly, I would just suggest where do we incorporate this new technique in our clinical practices? Studies shows that international data showed that we can use it for the comprehensive evaluation of chest pain, unclear cause of TID, and abnormal ECG with normal perfusion. And it improves the extent and severity of coronary artery disease detection. And it is very useful in the balanced ischemia for the prognosis and for the lack of vasodilator response. we usually repeat the scan and go for the calcium scoring as well. And it is very useful in suspected cases of microvascular disease. And in those cases, we see normal perfusion and anatomy, but there is lower value of MFR. And studies also show that it has improved the detection of viable myocardium. Typically, global MBFR greater than 2 correlates with an excellent prognosis and is reassuring. Low MBFR in the setting of no known disease requires further testing, and the lower the MBFR, greater the likelihood of multivessel disease and worsens the prognosis, and there is greater likelihood of benefit from the revascularization. There are certain limitations as well, and it is less helpful in patients with prior CABG, prior large infarcts, and end-stage renal disease. So while concluding, I would say that incorporating this dynamic technique in the conventional myocardial perfusion imaging, it provides complementary information to MPI and adds considerably to the value of improved diagnosis, prognosis, and quality assurance. Thank you very much.